I think good evening, listeners. Today we'll be discussing about fundamentals of neuropsychology, and we'll be mostly concentrating on memory. Okay, that's the main. Then we'll see what is the dementia syndrome. Okay, so just to recapitulate the broad main areas which I have shown, mostly should be able to identify the areas which are in frontal lobe, parietal lobe, occipital lobe, and temporal lobe, lateral aspect and medial aspect. To highlight certain functions of these lobes, the frontal lobe is very important, and it's responsible what you are at this stage and your development, thinking, planning, motor execution, executive functions, mood control, etc. Also, this anterior cingulate gyrus is also volitional movement, attention, and long-term memory. That's what anterior cingulate gyrus is, which is seen the medial aspect of the frontal lobe. The temporal lobe is language function and auditory perception. It's involved in long-term memory and emotion. And the posterior cingulate gyrus is attention, long-term memory. Again, the cingulate gyrus is very important. Parietal lobe, somatosensory perception, integration of visual and somatospatial information. The occipital lobe is the visual perception and spatial processing. The posterior cingulate gyrus, as I said earlier, attention long term. Parahippocampal gyrus, short term memory and attention. So these are the broad ideas of this. We'll go on to the next. So we'll see dementia. What is the dementia syndrome? What are its aspects? Dementia syndrome has mostly memory impairment, that is a short term and long term memory. It also has executive functions that are disturbed, which consists of abstract thinking, judgment, problem solving, and higher cortical functions like aphasia, apraxia, agnosia, and constitutional abilities and calculation. And if these are also affected in dementia syndrome, behavioral and emotional functions, the personality, the emotional control, the social behavior, motivation. Most important is social function. There should be a definite fall in activities of daily living, work relationships, social activities, and all should have a progressive deterioration, duration of symptoms more than 6 months, importantly. And there should be a decline in functional status, and consciousness should be preserved. These are the important. So, if you look at the dementia, there is an impairment, disabling impairment in multiple cognitive functions. It's not only memory loss alone, that's what is important. It has got other domains also, which we'll see. In respect of mild cognitive impairment, it can be a single domain when it is called, if it is only memory loss, it's called amnestic mild cognitive impairment. If language, executive function, and spatial geographical orientation is disturbed, then it's called non-amnestic. Or it can be multi-domain mild cognitive impairment, which is a harbinger of major dementia syndromes. And most important, primary degenerative dementia is Alzheimer's disease, and others are frontotemporal dementia, diffuse Lewy body disease, and all these three are fundamentally may be associated with vascular dementia, which is acquired condition. The preclinical Alzheimer's disease, which is the most common primary degenerative dementia, starts very early in life, and neuropathology, biomarkers, neuropsychology, and subjective cognition. When before the cognitive impairment, neuropathology changes have already started taking place. So, if you look at the right and left cerebral hemispheres, you can divide them in the neurobehavioral syndromes wise, which is given in the Handbook of Clinical Neurology. Left side, the frontal lobe dysfunction, you see distractibility, perseveration, lack of drive, impulsiveness. All these things will be affected in cases of frontal lobe dysfunction because of tumors or whatever it is, strokes and hematomas. In the left side, if you look, aphasia, agraphia, alexia, apraxia, acalculia, finger nose, agnosia, right left disorientation. These are the main defects. The posterior aspect has pure alexia, associate agnosia, color anomia, and prosopagnosia, and we are going to deal with them in our subsequent parts. Look at the right cerebral hemisphere. It is a hemispatial neglect and visuoconstructive disorders, topographonosia. The right cerebral hemisphere controls the left side, and importantly, the right side brain is important constructional apraxia. Also, the attention shifts in both the visual fields on right and left. Of course, it's important for visual memory. It's important for visual memory also. Verbal memory is left cerebral hemisphere. The brain is connected at various areas of the brain are connected with networks, brain networks. And there are 5 cognitive domains these networks serve, that is memory, the language, and attention and concentration, spatial cognition or spatial orientation, and executive control function. They're the most important domains which the neural networks observe, and they are fronto-subcortical network and memory, language, visual, spatial, intrinsic connectivity. You can see all of them. This is a perisylvian language network which connects the Wernicke's area with the Broca's area. You can see this is the important network which is subserving the language function. The limbic network, which is important for the retentive memory, so got amygdala and the hippocampus and the fornix, the mammillothalamic tract, and of course the amygdala. This is the limbic system, which is important for retentive memory. And same thing is depicted. You can see the hippocampus, the fornix, and the amygdala, which is the terminal part, and the mammillary bodies, which are the endpoints. From here, going to mammillothalamic tract. From thalamus, it goes to cingulate gyrus. This antepronosingular head. This is the limbic system, and which is called the Pepper circuit. The circuit we have already seen. This is the amygdala, hippocampus, everybody, and we'll in the next coming slides we'll see what's the major dentate gyrus and the hippocampal formation circuits. So the paratofrontal, the spatial retention network, can see the supplementary motor area, basal ganglion are connected to red nucleus, the spinal cord, it goes to the muscles, and this is another important paratofrontal spatial cognition network, which is very important. Attention and behavior, all parts of the brain are interconnected and subserve the attention. Attention is the most important function. If attention, we'll see how it is to be tested neuropsychologically, and attention is very important to be tested at the initial stages of cognitive assessment. Otherwise, you may not get good results with other cognitive tests. And occipital and temporal is very important. There are 2 streams which will go from the occipitotemporal region. Occipitotemporal region is there are 2 streams, the dorsal stream and the ventral stream. The dorsal stream is the where pathway in recognition to environment. Where are the things located? And all these memories, associate memories, are stored there and tapped and retrieved. Whereas the ventral stream goes to the temporal lobe, and so what pathway? It's called what pathway, and what is this, and what you are seeing, and especially what is this face, and what are these objects. So this goes to fusiform gyrus, and you can have facial recognition things. So dementia syndrome, it's not a disease, as you know. It has got more than 55 pathologies in it, and DSM-5 criteria is what we are presently using. There was DSM-3, DSM-4, DSM-3R, NINSE-ADS. There are many types of ICD criteria over there. Where dementia syndrome is suspected and you apply all these criteria, there will be different types of yield of correct dementia if we apply all the criteria. So right now, we are using DSM-5, and here it's now no more called as dementia. It's a major neurocognitive disorder. So memory is not very important. The only earlier criteria showed that memory in association with other defects. But here One or more acquired significant impairments in cognitive domains such as memory, language, execution of purposeful movements, that is apraxia, recognition and familiarity, agnosia, visuospatial function, which is topographical disorientation, self-control and management is executive functions impairment. So other things are calculations, prosody, and writing, reading skills. And these are all can be impaired, dysprosody, agraphia, dyscalculia. So any one or more of acquired significant impairments in cognitive domains. So in these domains, if there is, we can suspect the major cognitive impairment. So look at the memory. Memory is divided into long-term memory and short-term memory. There are various types of memory classifications which confuse us. The what you call iconic memory is a memory which either on seeing an object, on hearing an object, you tend to register for a second or 2 seconds, and from there, from the childhood, as the child grows, he keeps on accumulating these memories around the primary sensory areas, that is the somatosensory cortex for the somatosensory sensations, olfactory. ఏ నందు అమ్మతో మాట్లాడి క్లాస్లో ఉన్నా మళ్ళీ మాట్లాడు అమ్మతో మాట్లాడు ఓకే సో and the long term these memories they are stored in the surrounding areas of sensory areas, that is called unimodal association areas, and surrounding them all these unimodal association areas in the posterior aspect, that is auditory, olfactory, and auditory, visual and somatosensory, they keep on associating, is called heteromodal association area posterior. Anterior you have olfactory, limbic system. All these areas are called anterior heteromodal association areas, and whenever a concept is generated, all these association areas work together to develop thoughts and concepts. So in that, when you have to do something, you have to retrieve, you have to encode the memory, store the memory, and retrieve the memory. So these are the various aspects that will happen. Okay, so long-term memory can be declarative memory, and that is called explicit. Also, it can be non-declarative, that is implicit memory. The declarative memory is events related, the time-locked episodic memory, and facts of semantic memory. Semantic memory is what with what we grow, that is our knowledge, world knowledge, object knowledge, language knowledge, conceptual priming. All these things are facts. That is semantic memory. The episodic memory or events, time locked, specific personal experience from a particular time and place, which we'll discuss again. The short term memory, sensory memory, or working memory, we'll have to start with, we'll talk in coming slides. Just have a look at the non declarative implicit memory, that is motor memory, the procedural memory, motor and cognitive skills, perceptual representation system, the perceptual priming, classical conditioning, and non-associate learning like habituation, sensitization. These are non-declarative memory. It doesn't require hypothalamus, I mean, temporal lobe or hippocampal formation for recalling this. So that's how the introduction of the memory. Now, if you look at the historical aspects of memory, William James described a distinction between primary and secondary memory, where primary memory consisted of thoughts held for a short time in consciousness, and secondary memory consisted of a permanent unconscious system. In 1968, the three-part multi-store model was first described by Atkinson, and subsequently 1974, Bradley's model of working memory is a model of human memory proposed by Bradley and Hitch, which I'm going to show you. And this was revised in 2000, and episodic buffer is added. It's considered a limited capacity system that provides temporary storage of information by conjoining information from the subsidiary systems and the long-term memory into a single episodic representation. Let's look at this. The sensory memory, short-term memory, and long-term memory. So whenever memory is there, initially it goes into the buffer of recent memory. And so let us look at working memory, where it is located, perisylvian region. The recent memory is hippocampal formation, contented gyrus. And the remote memory is stored in a large amount of association cortex. Association cortex, the cortex that is apart from all the primary sensory areas, the olfactory, somatosensory, the visual and auditory, and all the other area where billions of neurons are there. That's association cortex. That's where the long-term memory is stored. So after that, we'll go on to the next. So multi-store model. What is this multi-store model which we're going to talk? This is sorry. There's a visual spatial sketchpad and a phonological loop, and there's a central executive. This is a Bradley model of working memory. Whatever you see enters the visual spatial sketchpad. Whatever here, the language person are going to phonological loop, and this is then they get into to the storage mode on consolidation mode. They enter the recent memory, which can last from days to weeks, and beyond 6 months if the memory is consolidated, it goes into the remote memory stage. So this is the model that is developed by Bradley. So main components are there's a central executive which acts as a supervisory system and controls the flow of information from visual and auditory into its slave systems, which we said the phonological loop and the visual spatial sketchpad. So they are holding these before they become permanent. So the working memory is a memory which you keep for a very short time. And it requires when your mind is bombarded with many impulses, you are trying to focus on one thing and keep it for a short time on your visual spatial or phonological loop and perform the task and forget about it. So maximum 7 items can be kept for a minute or so, and that vanishes. It's not going to be there. The working memory disturbance is the most important reason for the delirium. The phonological loop stores verbal content, whereas the visual spatial sketchpad caters to visual spatial data. Both these slave systems only function as short-term storage centers. Bradley added a third system to this model, the episodic buffer, which is a time traveler, which I will describe later. So, multiple forms of memory, the declarative memories, ability to re-experience past events is episodic memory. When did you go last to the market, and when did you visit a mall, what picture you have seen? These are all time locked. Whereas semantic memory is a fact. And what is this color? Banana, it's yellow. It grows on banana trees and it's eaten by monkeys. These are all facts. Remembering a new phone number while dialing it is working memory. The non-declarative memory is very important. The procedural memory, like riding a bike, playing the piano, shooting, all these things are uh, shooting basketball. All these things are learned at subcortical level, you can say. And the important thing is that procedural memory can be cultivated in Alzheimer's patients because it doesn't require a hippocampus to recall. So, Tolving in 1972, he talked about episodic memory. He said memory for personal experiences and their temporal relations. It's in fact a mental time travel, or it's a subjective sense of time. Autonoetic awareness, sense that remembered events are from past as distinct from the present experience, are noetic awareness. Sense of self as a time traveler. Whereas semantic memory, it's a system for receiving, retaining, transmitting information about meaning of words, concepts, and classification of concepts. Semantic memory is important because it is referring to concepts, facts, right? It has got no relationship to the time. If you want to know that semantic memory impairment is most commonly seen in frontotemporal dementias, where episodic memory impairment is not a big feature. In Alzheimer's disease, episodic memory impairment and anterograde learning defect constitute a very important aspect. So, the limbic system memory, which we have already discussed, and the medial temporal lobe memory systems, very important. And this subicular complex, entorhinal cortex, and perirhinal and parahippocampal cortices. And this is the hippocampus and dentate gyrus, and the tip of the amygdala is going at the fornix, and the mammillary body and mammillothalamic tracts, and which will go to the cingulate gyrus. So you can see when this lesion is impaired or it is removed in the epilepsy surgery, you can have some defects. So Bradley's, again, I'm just showing the central executive visual spatial sketch pad. That's for the visual semantics or visual facts. Episodic, this is a time related buffer, that is episodic buffer. Phonological loop, whatever language you are hearing. So this is the crystal system, means the fluid system. The fluid system is temporary systems. The crystal system means at least you are able to store them for the momentary verbal or visual spatial mental contents are the fluid systems, manipulation of this material and to remember it into the crystal system. So cortical memory systems are working memory, episodic memory, and semantic memory. And we have already discussed what are these. This semantic memory is usually located in. You can see that temporal poles or the semantic memory, whereas the medial temporal lobe and the dentate gyrus and hippocampal formation or the anatomic localization for episodic memory. The perisylvian area is important for working memory, and dorsolateral prefrontal cortex is important for executive control. So, what are the working memory impairments? Prefrontal atrophy in frontotemporal dementia. You can see the frontal lobe is atrophied in this, and the medial part also is atrophied, and it can have atrophy of the anterior temporal lobe also, and you can have logopenic primary progressive aphasias. So posterior temporoparietal atrophy, which is seen here, and posterior cortical atrophy, and Alzheimer's disease. Performance on the digit span, which we are going to learn in coming time. What are the digit span tests we'll discuss. So working memory impairment and prefrontal atrophy, frontotemporal dementia. So what are the disorders of working memory? Commonly declines in normal aging. It's particularly commonly affected in many neuropsychiatric disorders. Many forms of cerebrovascular disease, including stroke, multiple sclerosis, Parkinson's disease, and a core problem in delirium. So these are the memory systems of episodic memory and the medial temporal lobes. The dorsolateral convergence is in the association areas. What are the association areas? Visual association area is surrounding the visual cortex. Auditory association area surrounds the auditory primary cortex, and somatosensory association area surround. So all these three areas have to get interconnected in the heteromodal association areas. For example, if you want to say that a chap who has got an object which has got two two wheels and a handlebar and a seat, what do you call that? So you immediately say it's a cycle because you are bringing back your visual memory and whatever is stored about this particular aspect, the semantic aspects of this. That's all because of the coordination between the various association areas. And next. So medial temporal lobe memory system, which is depicted here, and you can see hippocampus, entorhinal cortex. This is entorhinal cortex, and perirhinal cortex, parahippocampal cortex comes, and unimodal association areas. And so this particular area, the frontal or the medial temporal lobe, which has got CA1, CA2 and 3, CA4, dentate gyrus, and subiculum. There is a reverberating circuit here. From the impulses that are coming from the association cortex, they enter the entorhinal cortex and go to CA1, then CA2, CA3, and also dentate gyrus come back. And some of these are going by. Their reverberating circuits happen in this. And as I saw from association cortex, you can see, and it's coming to entorhinal cortex. From there, it's going to dentate gyrus, and in that it is a CA3, go to CA1, subiculum. Again, it goes to the fornix. So association cortex project to the parahippocampal cortex, which in turn projects the entorhinal cortex. It's a gateway for entry of the highly elaborate information into the hippocampus. The hippocampal formation comprises dentate gyrus, CA1, CA2 and 3, and subiculum. The intrinsic circuit of this hippocampal formation involves feed-forward excitatory connections. There are ganglion cells in dentate gyrus, and they send excitatory neurons and moss fibers to CA3 pyramidal neurons. These project via Schaffer collaterals to CA1 pyramidal neurons, which project to the subiculum. So these are full of neurons and connections. The neocortex, the parahippocampal gyrus, and the hippocampal formation have reciprocal feed forward and feed backward connections. I was discussing earlier the association cortex, parahippocampal, internal cortex, subiculum, CA1, CA2, CA3. The association areas of the neocortex, they project to the perirenal and parahippocampal cortex. The neurons of the CA1 region and subiculum project back to the entorhinal cortex, which projects the neocortex. So this is a reverberating circuit, and that's very important for the recent memory. Episodic memories refer to the knowledge about temporally dated episodes of event or events and the temporal spatial relations among these events. And noted that such memory is stored in terms of its autobiographical reference. The processes that are involved in episodic memory, if you look at the encoding, the learning of new information, and what is required is a basic attention and working memory are very essential for encoding any information. Deeper encoding, that is processing semantic content using elaborative strategies, is associated with better memory. And after encoding this, it has to consolidate and it is stored. As the time passes, information becomes less dependent on the medial temporal lobe for recall. Retrieval, that is recall was recognition, and recognition means recollection and familiarity. So these are two aspects. These are the processes that are involved in the episodic memory. What and where visual streams, how information about objects and context is learned is encoding. Is the dorsal is the where pathway and the ventral is a what pathway. From the, you can see the, from the occipital cortex is on the where pathway and what pathway. And so these are the what pathway is important for faces and locations, whereas the where pathway is more important for location. The what pathway is more important for faces and recognitions. So these will be affected if there's any disease there. Some of these important aspects are to be remembered very much, and because these are, there is thinning in multiple cortical regions as shown here in mild Alzheimer's disease. When it has not become clinically evident, they can have various areas. The yellow is the area of thinning. So these disorders of episodic memory, if you look at, does not affect normal aging, Alzheimer's disease, temporal lobe epilepsy, limbic encephalitis, transient global amnesia, Korsakoff syndrome, anoxic hypoxic brain injury, depression, schizophrenia, even in viral herpes simplex encephalitis. Now we come to the semantic memory, which is defined as a memory necessary for the use of language. Your knowledge is basically due to semantic memory. It's a mental thesaurus, organized knowledge a person possesses about words, other verbal symbols, their meanings, and the reference, and about relations among them, and about the rules, formulas, algorithms for the manipulation of these symbols and concepts and relations. These are all semantic memory. Semantic memory is very important for a person's growth. Disorders include relatively uncommonly affected, spared in normal aging. It's affected in viral brain infection, mostly herpes simplex encephalitis, also unusual types of stroke, sometimes very specific to certain categories of information, such as tools when they do. Semantic dementia, and late in Alzheimer's disease. Semantic dementia is most common prone to temporal dementia. Because Alzheimer's disease, it comes late. The clinical implications for patients with memory symptoms that go beyond mini mental status examination to include focused tasks of memory, that is 5 to 10 item word list, semantically related words randomly presented to the individual. They are followed by immediate free recall, and you can't repeating this presentation for 3 to 5 times. You would have to record a learning curve and clustering, and so do some other task for some 10 to 20 minutes, come back and ask for a recall, semantically cued recall, and three choice recognition. So what happens is antegrade learning defect is key of the Alzheimer's disease. So race auditory verbal learning test or the small test, if you are not able to demonstrate progressive learning, that indicates Alzheimer's disease. And the second important thing is if you are able to remember with cues, that remember that is subcortical acquired dementia, it's not primary degenerative dementia. This is a very important test. And Probe informant and patient regarding remembered details of a recent event. Score percent of details is, retrieved with and without cues. So that's again indication of episodic memory. So neuropsychological assessment, there are five key investigations to map the pattern and distribution of the disease: orientation and alertness, language skills, literary skills, literacy, praxis skills, memory and perceptual skills, mini mental status examination, Queen Square screening test. So these are some of them. So why do we do this? It is to distinguish dementia from age-associated memory impairment, to detect focal psychological manifestations, to distinguish organic dementia from depression, to characterize cognitive capacity comprehensively and in detail, and to make appropriate recommendations regarding competence and financial responsibilities, driving and machinery, to provide longitudinal assessment on all these things are very important. So bedside testing, and you have to do orientation to time, place, and person. Immediate, short, remote memory, that is testing for episodic memories, recall a trip last week, fund of information, language, praxis, visuospatial construction tasks, insight, and judgment. So the clinical correlation is there may be some factors which can affect that age, gender, educational level, normal versus disease states, and episodic versus semantic, verbal with non-verbal memories. You have to test. Many tasks engage multiple domains. The very important, fascinating task is simple clock drawing test, which will tell you abstraction, visual motor domain, language domain, and executive control domain. The very important test and bedside test. So how do you test? Attention, digit span, serial reversals, months of years, continuous performance. You read whenever A is seen, you can ask the subject to tap number of a list of letters you can add mixed with A's. Observe and semantic fluency, comprehension, naming, repetition, read and write, language. The primary progressive aphasias, you have to do a detailed language assessment. It's not like strokes. You have to have well, auditory comprehension, visual spontaneous speech output, and the detailed repetition test, detailed naming test. So very important language, elaborate thing in dementias we have to do. Auditory verbal learning test, the screening for remote memory with current and historical events. There are two things here, and auditory verbal learning tests. It is helpful in delineating the antegrade learning defect in Alzheimer's disease. The 2D and 3D constructions, and they get us to visual, spatial, and perceptual abnormalities. And the ideomotor, ideational apraxias, imitations, gesture apraxis, and the anti abstractions and trail A, trail B test for executive control function. So, levels of assessment. There are four levels of assessment. First is brief screening, mini status examination. This takes 5 minutes. Orientation to time and place, the 10 points. Registration, 3 points. Attention calculation, you do 5 points. Recall, 3 points. And simple language, where you will ask them to identify simple objects and read and obey. And you repeat a sentence, what you tell him, and ask him to do a three-stage command, and ask him to draw a pentagon intersecting. So that's a brief screening test. And neuropsychological testing requires 3 hours, but neurobehavioral status examination may take unlimited, can get specific areas for a long time. So the short Kochman mental test, if you look at that, and you see maximum score of orientation is 8 points, where your name, address, current location, that is built city, state, date, month, year. Digit span present at 1 per second. Record longest correct span 29683571946 is 7 maximum score. There's a rule of 7 plus minus 2 is the information we can keep temporarily on our working memory buffer. Learning and immediate recall. Learn our unrelated words: apple, Mr. Johnson, charity, tunnel. Record the number of trials for acquisition. Maximum 4 trials. You can see how many words you can Learn calculation 5 into 13, 65 minus 7, 58 by 2, 29 plus 11. So that means you are doing calculations, subtractions, multiplications, divisions, and additions. And you can similarities and abstractions can be tested. Orange and banana, you can ask them. Dog and horse, what is the difference? Table and bookcase. So these are the some of the information you can elicit. President, first president, number of weeks per year, define an island. These are the informations which are stored on your testing. Copy the cube, draw a clock face showing 11:10, and the four-word Apple, Miss Johnson, Charity, and Tunnel, which you earlier said, learning and immediate stage. Then you call them that. The score is 38. Some of the subset scores, number of trials for acquisition. For example, if a patient learn all the four words in the first trial, nothing is subtracted from some of the subtest scores. If a patient required four trials to learn the four words, then three was subtracted from the sum of the subtest score. So this is called Kochman short mental test. This is very important, and this is different from mini mental status examination. Right. This is the MMSC test, which we are all know. That is orientation, registering, what I was telling, attention, calculation, and recall. And this is also 30 score. You can see the two objects, two repetition one, three-stage command three. It has a lot of marks. And take a paper in your hand, fold it in half, and put it on the floor, and read and obey. That is 1 mark. Write a sentence, 1 mark. Copy the design shown. That's 1 mark. So these are very important 6 items. That is, and 1, 2, 3, 4, 5, 6, and 7 items. So these are 7 items are very important in the language. So this is screening test. Now, whatever abnormalities are there, if the score is less than 26, depends on education also. The 12th pass or the 7th pass, the degree pass, the scores are different. And illiterates also, illiterates can do only few of them. So there are validated scores for this test. Very important for all students to do this, and they don't usually do it even though they know about it. You look at the frontal lobe. If you look at the frontal lobe, for working memory, set shifting, the trail making test E and B, sequencing test, fist, edge, palm, 3 times with examiner and 3 times alone. You have to see whether he's able to do this or not. Verbal similarities, how they are alike, orange and bananas. That is the abstraction. Verbal fluency test, inhibitory control, go, no, go test. Go, no, go test. For some of these things I'll again elaborate. Digit substitution test. You can have digit substitution test, which is available on net. You can see and learn. So temporal lobe, recent memory. Left temporal lobe is verbal memory, auditory verbal learning test. Right temporal lobe, visual memory test. And there is a visual memory. You can ask to look at 3 items which you have drawn: a triangle, a square, and a circle, and immediately close and ask him to redraw again. That visual memory is tested for the immediate. Then you can ask after some time what you've done. Remote memories, birthplace, when did you start working? These are episodic components of remote memory. Semantic memory, historical facts, date of independence, Gandhi Jayanti. So the parietal, you got a dominant and non-dominant. Dominant is apraxias, calculation, right-left orientation. Non-dominant, neglect. It could be visual, tactile, and auditory neglect. Visual target cancellation, constructional apraxia. So parietal lobe has got right dominant, left dominant and right non-dominant hemisphere dysfunctions. Occipital, visual object agnosias, autotopognosia and asterognosis, and prosopagnosia, inability to identify the faces. So in summary, you have all these cognitive function tests. Then you can say what are the cortical functions that are impaired. Is it subcortical or cortical? What are lobes affected? Frontal, temporal, parietal, occipital, and tentative localization, clinical diagnosis, and management plan. So if you look at what are the important principles of cognitive testing. Or these principles, the mental status examination is hierarchical. Absent responses can be interpreted as abnormal. It mostly involves pathognomonic cutoffs. An abnormal test corresponds with a single impaired cognitive area, A and C above or all of the above. If you look at this, the answer to this, what are the important principles of cognitive testing, which we, anyway, I don't have time to ask and elicit. So, general principles I can tell now. Specific cognitive testing, brief screening, mental status examination, MMSE, MOCA scales are important. Neuropsychological testing, neurobehavioral test, status exam comes next. These tests that are brief and in public domain are very useful, and there are some cutoffs. Test each area with more than one task. Like that means frontal lobe, you do more than one task, and you want one test. Temporal lobe, more than one test. So at least how many you should be made to do? At least minimum four if you can. And normal or abnormal. If more than three out of four, it's abnormal. And context, and I mean, if you're not able to do, if you're able to do three, that's okay, that's normal. And confounding variables, that hierarchical attention impacts memory. So attention is the first important test you have to do. So mental status symptoms, yes, extended mental status examination, usually including the mental status scale. If it's not, then screening karo, then forget and follow up later. The 5 minutes brief mental status examination comprises these five important domains, which I initially mentioned. Arousal and attention is tested with digit span, orientation to time and place. And these tests response to physical and verbal stimuli. There may be distractibility, so be careful. Name six common items to confrontation category: animals, word list per minute. How many words a person can talk in a minute is about 100 words. 3 to 4 list learning task for 5 minutes. Copy increasing pentagons and a cube, clock drawing test that will give you perception difficulties idea. And personality and emotions, observe interpersonal emotional behavior and insight. So the MMSC, MOCA, and scales, they are good for quantifying over time. Adequate test, retest, and inter-rater reliabilities are there, more than 0.89, and they are valid, well validated with alternate form. They're not specific for focal deficits. If they are very much educated, these tests may be appear normal, even though there is some abnormality. That's called ceiling effect. They do not assess all cognitive abilities. So MOCA is recommended because it is derived from neurobehavioral status exam, which is at UCLA, and includes more cognitive domains. That's why MOCA is a very important test. And indications for neuropsychological testing, if there are mild deficits and distinguished from age and education norms, that is ceiling effect. You want to differentiate dementia versus pseudo dementia. Determine the extent of impairment for rehab program, detailed and functional assessment, capacity or competency determination, and medical legal aspects. So, given the clinical problem, all are acceptable levels of cognitive assessment except what? And you can see patients with cognitive features as part of the neurological disorder, patients with progressive non-amnestic difficulty in cognition, medical legal assessment of patient in motor vehicle accident. Also, you do neuropsychological testing. Follow-up of elderly person with memory complaint, you do screening scale. And emergency department patient suspected delirium, brief screening with mental status examination. MSEX means mental status examination. So patients with cognitive features as a part of neurological, so neurobehavioral status examination. Patients with progressive non-amnestic difficulty in cognition, brief mental status. Medical legal assessment. So what is important in this is patients with progressive non-amnestic difficulty in cognition cannot be no satisfied only with brief status. We have to do a detailed test. So neurobehavioral examination, fundamental is, as I said earlier, attention. Instrumental, you have to look for memory, language, visuospatial, perceptual, limb praxis, and executive functions. This is a cognitive test scheme. So fundamental function, patient should be arousal, attention should be intact, he should be wakeful, and the sustained attention should be there. And initiation, latency of onset, psychomotor speed can be assessed. Mental control is a mixed fundamental executive concept that includes working memory. Working memory, we have already said how to test. So now we are again telling you this fundamental important attention test. The two examples, you can see the digit span. Tell the patient, I am going to read a list of numbers. Listen carefully, and when I am finished, repeat the same numbers after me. Present the digits in a normal tone of voice at a rate of one digit per second. 2, 4, 9. Yes, tell again. 8, 5, 2, 7. Like that, you go on up to 8 numbers and 8 digits forward and ask them to repeat similar digit backwards. That's the first test for attention. A test, direction. Tell the patient, I'm going to read you a long series of letters. Whenever you hear the letter A, indicate by tapping the desk. To read the following letter list in a normal tone at a rate of one letter per second. Read only one line one unless you need a larger sample. So how many omissions? How many commissions? So what disorder is most characterized by abnormalities in digit span, serial reversals, and continuous performance? If you are asked, so let me see what it is. This. Yeah, I don't know what is this chart means. Okay. What disorder is most characterized by abnormalities in digit span, serial reversals, and continuous? What is it? Delirium. What disorder? Mostly what you can see where the attention is delirium. Delirium is a thing which is affected. So attention. What are the tests for attention or trail making test A and B? It may take 5 to 10 minutes. Digit span forward 3 to 5 minutes. This span backwards, it will take 3 to 5 minutes. Sequential operations is months of the year backward, if you say. That means of three. And Stroop test. Stroop is a color test which you can look up, and that will take 7 to 10 minutes. So if you want to test cognitive domain of attention, these are the tests that you have to do. Then look at the language, 6 elements. First, you observe the fluency, listen for fluency, comprehension, follow simple pointing commands, that is visual comprehension, and verbal comprehension, auditory comprehension. Repeat the sentence, no ifs, ands, or buts. Naming, point to 4 items and name, ask them to name, that is, you can have diagrams, and read brief sentence and write brief sentence. So fluency, if you look at the fluency, what is the fluency? The words per minute, more than 100 is fluent, less than 50 is not fluent. The phrase length, 5 to 8 words is the phrase, that's the fluent chaps, and the 1 to 2 words for phrase, that is a non-fluent. In fluent, there will be no agrammatism, but non-fluent aphasia, it is present and it will be telegraphic. The content in fluent thing is empty, paraphasic, but non-fluent high content words. The normal effort, there is no hesitancy, whereas non-fluent and Broca's is effortful and hesitant. Speech appears normal in fluent, dysarthric and dysprosody in non-fluent aphasia. The word disorder is most characterized by abnormalities in observed fluency, confrontational naming, repetition, reading, and writing. Now, what's the disorder that has all these characteristics? That is Broca's aphasia or primary progressive aphasia, where you can encounter all these problems. The right temporal lobectomy was done and delayed recall in this epilepsy patient. He could not lay any new information, he could not incorporate any new knowledge. So cognitive language, Boston naming test, 15 item short form, 3 to 5 minutes. You can have paired associate word test, which can take 5 minutes. Category fluency, you can do. So all this administration, these are the language tests. Now, if you look at the visual spatial perception function, what are the test constructions? Complex figures, clock drawing, and digit cancellation test. And you can special perception like face recognition. You can have number of photos and ask them to identify the faces. So these are the diagrams which you can show and identify what are the designs. Clinical approach made, and you can see that how the affected individual is drawing various designs. So that's the visual perception. This thing you can ask them to draw various types of clocks, which you can see. And this is abstraction. as well as geographical orientation, executive control function, and also it's a type of language testing. And also you can see cancellations, digit cancellations, and the complex figure which they can draw in with a special this thing. And you can see face recognition, what these faces. What disorder is most characterized by abnormalities in 2D and 3D constructions, set cancellation, figure ground discrimination. See, there are abnormalities. There are abnormalities, posterior cortical atrophy and Ballinet syndrome. The most important, fascinating things happen whenever you have this variant of Alzheimer's disease, that is posterior cortical atrophy. Then praxis. We're going to praxis. What is praxis? Apraxia defined by the loss of the ability to perform purposeful skilled movements when this deficit cannot be explained by motor deficits, weakness, sensory defects, movements disorders, tremor, ataxia, chorea, athetosis, balismus, myoclonus, or certain cognitive disorders, poor comprehension. There are five major types of apraxia one has to know, and each are defined by the task it demands and types of errors that can be made. Limb kinetic, ideomotor, dissociation and conduction, ideational and conceptual. These are the types of apraxias which we know. And you can see the visual input, object units, visual gesture input, movement representation, sorry, and action semantics. It's the auditory input, lexical semantics. So what happens from there? They go to premotor cortex, cross the corpus callosum to other premotor cortex, and motor cortex on either side gets activated and send impulses to the spinal cord for performance of tasks. So that's called the spinal cord. This is a praxis system, and any the lesions occur here, giving rise to apraxia. This is the praxis system which you should know. Visual input, visual gesture input, auditory input. All these inputs, they are stored in the association areas surrounding. Okay. Now, ideomotor apraxia and upper limb, brush the teeth, flip a coin, salute, and this ask him to do all this stuff. Buccofacial, blow out a match, lick the lips, kick a ball, figure of eight, you make a drawing. Although if you want to test the whole body ideomotor apraxia, to say how you bow, how the boxer stands, imitate all these pantomimes. So ideomotor fail to mime and imitate. Parietal type may not understand the gestures. Disconnection type, they understand gestures but cannot perform. Impaired language comprehension, dissociation syndrome, which we'll see in the end, that is a corpus callosum dissociation. Impaired loss of meaning in dementia is conceptual. Impaired from decreased dexterity, and that is limb kinetic, will not be able to do tasks. What localization is most characterized by abnormalities in upper extremity, mime, imitation, and possibly gesture comprehension? The parietal lobe abnormalities. Left parietal region can be seen with bilateral lesions, but worse on the left side, especially in corticobasal syndrome. So, what is this question? All ideomotor apraxia patients fail to mime. All ideomotor apraxia patients can imitate. Ideomotor apraxia disconnection subtype differs from parietal subtype in understanding gestures. Dissociative apraxia is a language problem. Conceptual apraxia is common in dementia. So, which is correct in all these statements? What we made is all ideomotor apraxia patients can imitate. So, imitation is not a problem, miming is a problem in these people. So ideomotor apraxia, parietal and callosal, you can see. The lesion is in corpus callosum, inferior parietal lobe, angular gyrus, motor sensory changes, poor pantomime. Okay, and that is the language component is abnormal. So constructional apraxia on the right side. So visual stimulus is required to draw a diagram, to draw intersecting pentagons, or to read also. So what it does is when your visual stimulus, spatial working memory, mental representations of geometric and semantics come out and motor output. And if there is an impairment, you got constructional apraxia. And these are the various, the circuit of apraxia is depicted here. A is dissociation apraxia, that is Here, lexical semantics are cut, object recognition units are cut. So then you can have the dissociation type. And B is conceptual apraxia, that is action tool semantics are cut. So that's where you can get the action. Ideomotor apraxia, see the connections. You can see the connections that are cut to the supplementary motor area, and that's one aspect. And supplemental premotor cortex, that's another aspect. The movement formulas of they are disconnected, so these all will cause ideomotor apraxia. Limb kinetic apraxia is motor cortex, and the thing that is going to spinal cord is disturbed. And conduction apraxia, that is E, that is a conduction apraxia, is from the inputs, the cut. So these are the various, these are circuits of apraxia. The spatial cognition, your cube copy test, cancellation test, line bisection test, these will take few minutes times. Okay. Now we're going to the memory testing, and which we have already read this. Immediate registration. Delayed recall, 3 to 4 words at 5 to 30 minutes. The arbitrary auditory verbal learning test, then you can refer it and note down all the words and practice. Recognition part of the word list, visual figure recognition. Remote memory, 3 current events, 3 major historical events. You can ask, what disorder is most characterized by predominant abnormalities in auditory verbal learning and delayed recall? Alzheimer's disease. Okay. The delayed recall is most sensitive to memory deficit. Recognition, recall distinguishes storage versus retrieval deficit. So recall is delayed. And Montreal Cognitive Assessment, 5 word list in 2 learning trials. Delayed recall, 0 to 5, quantitative. Category Q, multiple choice, qualitative. Queuing will help in subcortical dementia. The verbal episodic memory, word list learning. The encoding is tested by repeat 3 words. Whatever words you are telling, they have to register. That is what is encoding. You have to retain information over time, that is storage, and you have to access this information. What were those 3 words? So that these tests are, if recall is less than 3, it is a storage or a retrieval problem. Retrieval deficit is aided by clue or multiple choice question, that is subcortical. Retrieval problem is subcortical, whereas storage and encoding is storage a problem. Encoding deficit, impaired attention, and that is where you get depression, anxiety, and delirium. This encoding defect. Retrieval defect is the problem of mild cognitive impairment, depression, and fronto-subcortical disorders, subcortical dementias. What I said is storage deficit is mainly MCI, and so these are 3 steps: encoding, storage, and retrieval. And retrieval deficit is often aided by clue or multiple choice that suggests that it is subcortical or fronto-subcortical circuit disorders. So this is the end-to-end cortex. Cerebellum, CA1, CA2, CA3, CA4 dentate gyrus, and it goes to the. So this is the episodic memory dual processing model, which we have already discussed this a number of times, and I'm not going to go into the details, but whatever shown in diagram, that's what the circuit which reverberates, which goes into from the entorhinal cortex and the parahippocampus of sensory specific and multimodal association limbic cortices send information to the perirhinal and parahippocampal cortices, which then enters the entorhinal cortex, goes to dentate gyrus, CA3 region of hippocampus, CA1 region of hippocampus, and the subiculum. Then it goes to amygdala, prefrontal cortex, anterior nucleus of thalamus, nucleus accumbens, and distal subiculum, and goes back. So this is a circuit episodic memory dual processing model. And what is the test you do? Word list learning, it takes about 5 to 10 minutes. Trace auditory verbal learning test about 15 minutes. That takes longer time. Now go to agnosias, impaired awareness or recognition, visual agnosia, object recognition, facial recognition, that is prosopagnosia. Linguistic or non-linguistic recognition problems, and you're not able to identify the letters. Tactile is cortical sensory loss, graphesthesia. Prosopagnosia, impaired recognition of familiar faces. Apperceptive and associated types are there. And what is involved is fusiform face area. Capgras syndrome, spouse versus an imposter, developmental prosopagnosia. Most important is fusiform face area, which is responsible for the prosopagnosia types. Impaired recognition of familiar faces. And Capgras syndrome, which we have already seen, this is an I just enlarged diagram to show you the fusiform face area and straight cortex. Anosognosia is unawareness of a paralyzed limb, general clinical construct for unawareness of deficits that happens in the right hemisphere strokes, measured by clinicians' judgment or discrepancy scores. In Alzheimer's disease patients, highly variable, clinically significant association with apathy, frontal executive deficits, and dorsolateral prefrontal cortex involvement, because anosognosia on the right side especially. So these are the right procerebellum amyloid plaque density correlated with anosognosia and Alzheimer's disease. This is the area of the middle that will give rise to anosognosia. The projections are disturbed, and these projections we have already seen. We're not going to the details of this. And so executive control function, how we're going to do that. The Alexander Luria, that's frontal assessment battery test, usually verbal fluency, motor series programming, Luria alternating program, go no go test. And you can see this is the trial test, and you can see A is connected, 1 is connected to A, is connected to 2 is connected to B, B is connected to 3, 3 on C, 4 is connected to. This is the trial B test. If you are connecting 1 to 2, 2 to 3, 3 to 4, that is not that is trial A test. This is slap, fist, and cut. This is the so verbal fluency, phonomic fluency, letter. What are the letter words starting with S, F, A, S, sensitive to frontal lobe regions, and that happens in stroke and trauma. Normally, you can generate about 10 to 11 words per minute. Semantic category, that is phonemic, this semantic, animals, grocery items. This is also sensitive to frontal and temporal function, especially Alzheimer's disease. 17 to 18, more sensitive to age and education. That means if you are more educated, you can do it easily. It reflects integrity of semantic processing networks, that is default mode networks, medial temporal lobe, posterior cingulate gyrus, anterior and lateral temporal regions. They also provides insight into the executive control. The verbal fluency comparisons, you can see the normal controls. Semantic is more than phonemic. This is phonemic is VF, that is a black one. Semantic is more. In the mild cognitive impairment, there is a decrease in semantic, which is more than phonemic. The phonemic is this, semantic. You see, semantic has come down in minimal cognitive. In AD, both semantic fluency and phonemic fluency comes down. So these are the animals, how you do the test and how to generate the word lists. Cognitive profile, memory deficit, storage deficit. It's a MOCA. 0 to 1 correct on delayed recall. It's not helped by any category Q, and also not aware of any memory deficit. Semantic fluency relatively impaired versus category fluency. Category fluency and semantic fluency, we have just discussed how to differentiate. 12 animals or 12 F words. Impaired cube copying, naming, clock drawing. So utilization behavior is also again another uh, frontal syndrome, and you can have a person, if he sees a carpet, he starts using that. If somebody else is doing some, the other chap also does the same thing. You can see what he's doing, what he's imitating. So this is how you document your reports, which we can copy. So what localization is most characterized by abnormalities in the mental control, anti-abstraction, shows environmental dependency, frontal battery. These are all frontotemporal dementia, frontal lobe disorders. So visual motor integration, constructional practices, parietal lobe plays different roles. Right hemisphere, external forms, gestalt. Left hemisphere, internal details. That's parietal lobe. That is the dorsal stream that's happening. What is the difference between Alzheimer's disease? It has got a performance that is correlated with right parietal volume, spatial perception, spatial planning test. Whereas behavioral variant from the temporal performance correlated with dorsolateral prefrontal cortex volume and spatial working memory and spatial attention tests. So there's slight difference in this thing, and you can see the figure copying, pentagon copying, and these are the visual spatial, and you can see the Alzheimer's disease and diffuse Lewy body disease. Pentagon copying is more impaired in dementia with Lewy bodies than in Alzheimer's disease because it involves more areas. So exit control function, and you can see all these can be done in 10 to 15 minutes time. Now disconnection syndromes. Let's discuss a case. A 48-year-old male presented with 5-month history of short-term memory and word finding difficulties. The MMSE is 22 by 30, where attention, executive, construction, and these are the main deficits. Praxis, left to right orientation was intact. There's hypophonic speech, masked faces, deep tendon jerks, left more than right, left side Babinski, equivalent, that is normal. These are the tests which the clock drawing, you can see the various copying tests, right? The frontal lobe tests, you can see, and the difficult picture copying or drawing. For next 3 months, a rapid decline in gait and functional abilities, dressing apraxia developed, bumping into things on the left side. There's oculomotor apraxia, lid opening apraxia, color anomia, constructional apraxia, Justman syndrome of acalaglia, dysgraphia, left-right confusion, finger agnosia developed, and you can see the write your name, right hand, left hand, how does draw a circle, draw a triangle, write a sentence, bisect a line, copy, and these are the various things which he could not do. And see, this is the overall picture of disconnection. What happens? This parietal lobe, premotor cortex. The information has to go to the other side for proper functioning. The visual input is coming into the inferior parietal lobe. It goes to the other side, to inferior parietal lobe. It goes to the premotor cortex. And somatosensory association areas, visual association areas, auditory association areas, they all have to be tapped for proper production. So all this is the exact summary of what sensory neglect. Left side, right side, there will be nothing because the right cerebral hemisphere is defect. Tactile agnosia, apraxia, agraphia, and grasp reflex. These are the types of defects we see. So disconnection syndrome, key features: apraxias, aphasia, agnosias, alien hand also, bilateral, asymmetrical, multifocal to diffuse, sometimes progressive rapidly, but insidious onset. And you can see the disconnections of various disconnections you can see. And 1 or 2 months later, the disconnection is done. So disconnection syndrome, PET scan marked decreased hypermetabolism, non-diagnostic, 4 months or so. Postmortem consistent or documented leukodystrophy, gray matter unaffected. Multiple syndromes of higher cortical dysfunction due to white matter disconnection. See, disconnection is not only corpus callosum. The disconnection can happen in the networks which I showed you in the earlier slides. So, what is alien hand syndrome? First described in 72 by Brown and his partner in patients with corpus callosum tumors. Denial of ownership, feeling of foreignness and autonomous activity of the hand. There is an interhemispheric transcallosal sensory motor disconnection. There are other associated findings like tactile anomia, limb apraxia, grasp reflex, and hypomyoclonus. Intermanual conflict happens here. Alien hand syndrome and alien, and this, unless you see this, you cannot. The individual feels that it is not his hand. And these are the yellow areas. Alien hand syndrome is a major disconnection syndrome of a limb from supplementary motor area. The disconnection is from the supplementary motor area, which you can see. This is a functional MRI of alien hand syndrome. Cortical basal syndrome, alien hand syndrome. So the cortical basal syndrome and cortical basal syndrome, unraveling cortical syndrome and alien limb syndrome with structured brain imaging, you can see the areas which are damaged or marked in color. So summary cognitive testing, primary aim of cognitive testing is to provide objective data regarding real life functioning. Cognitive testing can be done in a brief, systematic way. Cognitive profiling facilitates differential diagnosis in relation to brain behavior relationships eventually should be more routine and more focused on brain fitness. So I think that finishes our cognitive assessment: attention, language, memory, visual spatial, praxis, executive function. These are the six domains which you have to concentrate. And to narrate once again: digit span, serial reversals, months of years, continuous performance, year test, observed semantic fluency, comprehension, naming, repetition, reading, writing, that's the language, and auditory verbal learning test, remote memory with current and historical events, visual spatial perceptual, 2D and 3D constructions, digit cancellation test, praxis, upper extremity mimes, imitations, gesture comprehensions, mental control, clock drawing, executive control, abstractions, environmental dependency, and frontal batteries. So these are the summary of cognitive assessment. I think that finishes the class today of neuropsychological assessment. We may take up something else in the next classes. That finishes our dementia lecture. And last year, I think September, I have taken about dementia syndrome and various other aspects. This is the second part. There is any question or anything which you can ask. Otherwise, I think we can close. Any questions? You can unmute and you can ask. You want, you can ask. Hope all you followed. Somebody can talk. Nobody asked anything. Could you follow?
Yes, sir.
So any doubts or any questions? And we tried covering a lot of domains which we usually have to do bedside. Okay, if there are no questions, and thank you very much. Good night.
Thank you, sir.